Sometimes we say if the first person's pulse you should check when you go into a room is probably your own. As the situation may become unraveling more and more, there sometimes can be a sense of calmness that comes over you. And be honest, that calmness is what makes the room successful. It's kind of like that high performance athlete that as the game goes faster, everything actually slows down for them. If the physician who's the leader of the room or the captain of the ship at the time is showing their anxiety in an outward fashion, those that have a lesser education or lesser ability begin to panic, and then the team kind of falls apart.
You've arrived at the Mental Health Spotlight podcast with therapist Kais. Dr. Jason Milk is my guest today. He is part of my First Responders series, and he is talking about being a physician in the emergency room and the staff and the impact of that. It's a great story to highlight yet another unique struggle for mental health in our community with first responders. Please listen, Dr. Jason Milk, right here. Peace. I'm going to assume, Jason Milk, you are very busy because your role has got to keep you busy. Not just the one thing I found out you did, but then the other. So in welcoming you, introducing you, can you tell us a little bit about what you do and why you are so busy?
Yeah. So my name is Dr. Jason Milk. I am an emergency room physician for the Cleveland Clinic. My primary role is a medical director of an emergency department. And then in a larger role, I supervise 6 total emergency departments in the management of their care, roughly 350,000 visits, and kind of the oversight and directorship and mentorship of the clinicians that work at those sites.
That's a lot. The last part is what blew my mind, that you're not just in charge of you.
Correct.
There's a lot of people. And I don't think I heard that number before. That many patient contacts.
All of the sites combined, yeah.
That's a lot. Well, Cleveland Clinic is huge here. I mean, you're in one part of it, but.
Yes, ma'am.
So question to you is, why medical, why ER? What got you to where you're at right now? Because you got here pretty quick too. So there's probably a story in that.
Yeah. So I grew up, my parents, were great. Never went to college. So there wasn't a lot of that. I was always told very young, you're going to college, right? And but there wasn't really a lot of direction on that path to get there. And my father was a volunteer fireman paramedic. And so I kind of grew up climbing on the fire trucks and understanding how helping people was important as he kind of lived that in his life as a volunteer. So I think that was probably that introduction into helping people and what that really meant, to that value was discussed in my house and what that was like. And I know my mom even shared with me that, she gave me a paper I wrote in like 3rd grade or 4th grade or whatever. I was going to be a doctor someday, right? There's a stethoscope drawn on the front. Incidentally, it ends with that I was going to be a lawyer too, in case I wasn't a very good doctor and got sued. I was going to be a doctor and a lawyer. I think that was probably some of my humor as a small child nonetheless, but that's where the journey began.
I love that. And it's nice when it comes from someplace sort of authentic and you saw it in your family and then you bred it in yourself. Are you allowed to talk about where you went to school? I'm always curious where people follow their medical paths.
Yeah, so I'm not a traditional path into medicine. I did my undergrad at Gannon University, which is in Erie, Pennsylvania. Graduated actually with a nursing degree. Granted, undergrad was difficult, challenge, not a lot of that mentorship. I started out pre-med bio, going towards that medical school track. Life got tough, changed paths into nursing, knowing I always wanted to kind of help people. Thought maybe I'd do the nurse practitioner route. Seemed easier and less difficult along the way. I was in the process of, heading towards nurse practitioner school, and a very brilliant, talented, and amazing young lady who was my wife and is my wife told me, look, you're going to end up in medical school anyway, so let's just cut to the chase. And so I dropped out of the nurse practitioner program, re-enrolled at Gannon to get the credits I needed, and then went to medical school. So I went to LECOM, Lake Erie College of Osteopathic Medicine, that is also in Erie, PA. We had a family at the time, so it kind of made sense to kind of go that direction.
I like that the path kind of swerved a little bit. I love when paths aren't linear. It's kind of real to me.
Yeah, I think, in the greater scheme of medical training, I think it made me a little more well-rounded, having a nursing background. I joke with people, I had many careers in a hospital. From a PCNA at bedside as a tech, transport to, all the way to being a physician and leader, director.
But you stayed in the same zone, a helper. That was the theme that has overarched it.
Correct.
And NPs fascinate me now because in our mental health practice, maybe this was before COVID or COVID changed that, but we don't see as many psychiatrists treating our clients. It's really a lot of nurse practitioners with the psychiatric specialty. That seems to be a huge thing right now.
Well, I think there's been a need in mental health care coming out of the pandemic, and even before, it probably was under-recognized and more prevalent. And honestly, medical, the medicine in general is slow to pivot, right? It takes a long time to become a physician, and residency slots opening up and expansion. It takes time. And so Obviously, the realm of nurse practitioners is a lot shorter road. Nurses that are already out there can get their NP and specialize in different areas. So I think that helps to fill that gap that's there, both PAs and NPs. And I think we're going to see that into the future.
Yeah, and it's been helpful to us because our clients can get seen now a lot quicker. The psychiatrists were just full. They just had too much. And interestingly, it's a slightly different approach. It's not better or worse, it's different, like, which is a testament to you going a couple different paths to get here.
Mhm.
So I'm not sure how you did all that. You divulged your age to me in our call. I won't pull it out unless you want to, but you did all that in a very short period of time.
Sure. Yeah, I mean, I guess in a traditional sense, if you're going to go straight through medicine to emergency medicine, you get there at around 29, age 30, somewhere in that way. I worked for 4 years in between undergrad and medical school, which probably helped that maturation process. So when I actually completed emergency medicine residency and got into the career world where I was at the bedside, I did matriculate into leadership a little quicker, but some of that might have been maturity that I carried
Yeah.
through. Some people, you got to practice for 10 years or more before you kind of have enough of a balance to take on to that next challenge. And I did it at year 4. So again, some of it's opportunities too. There was a little bit of a shakeup in the job market in this area, and the opportunity arose. So any advice to young people, if you have opportunities, come to those who say yes. And I could have said no at that time, but I said yes, and I kind of marched that path forward. It's been successful for me. Doesn't mean that every day has been success, but I'm walking the path of success.
And if you hadn't said yes, I have a feeling that wonderful person you described as your wife might have had something to do with that.
Well,
She
actually,
sounds pretty important.
honestly, at the time, I think she told me to say no because it seemed like,
Really? Okay.
well, with a young family and everything else, it seemed like
Yeah.
more work and a little bit of an uncharted path because of the changes that were happening in the healthcare market at the time. Anyway, I think I saw the future, and in this regard, it was probably more mine to say, trust me and just come along, we'll do
Yeah.
okay. And it ended up working out.
It ended up working out. Now, how did your love of medicine and helping, how did that get you to what we're going to talk a lot about, which is the ER and sort of that first responder safety force kind of role?
Yeah, I think what led me to emergency medicine, I think a lot of people either kind of are into the fast pace. I don't want to say chaos. We call it controlled chaos. There's a lot of stuff going on in any ER, depending on the size and the scope of it. We all kind of jokingly say, I have my chaos, you have your chaos, you manage yours, I'll manage mine, and we'll all do fine together. But I think a lot of it is born out of, as I met and I continue to meet people in emergency medicine on a daily basis, we all kind of have some common threads in there. We all like that fast-paced nature of it. We all like kind of showing up at work and not really knowing what is going to happen next. I don't have a schedule when I show up at work. I don't know who I'm going to meet. I joke with patients that some people will ask me, do you have an office that I can come see you again in? And I said, well, you're in my office. My goal is have you never come and see me again. And that's not personal. It's to make you better and not have you come back. But I try to tell people I try to make a difference in the lives of 30 different people every day that I work. They may be different people. Every now and again, you get to meet the same people. And I apologize immensely when some people say, you took care of me before and I don't remember. And that's hard. I look back in the record and jokingly, sometimes it wasn't me, it was somebody else and maybe it just looks like me, but nonetheless.
Because they're in crisis.
Yeah, nonetheless, I have a common last name, so usually they're right. With that said, that's kind of the challenge that brings us to emergency medicine. I think we like the fast-paced nature of it. We like doing different things. We like having the opportunity to do something related to orthopedics at one moment and something that might be cardiothoracic or cardiovascular or obstetrics. And we really can evolve into, 1 hour you can deliver a baby and the next minute you may be doing a resuscitation. So that can happen on any given day. And so there are highs and there are lows. And we often say too that, I get to meet people on sometimes their best day and sometimes their worst day. And my goal is to help them through both avenues of that.
I love how you also highlighted there's so much variety. I think you would be constantly, your dopamine highway is like up here. You're constantly riding something new.
And driven higher by caffeine. So.
Yeah. Well, and I've got mine here too. Yeah, we have to. This is a question, we might have even talked about this when we weren't recording, but I'm always fascinated by people in your role, whether it's a firefighter, police officer, ER. It's fight or flight all the time. It's that unpredictable, in your face. Were you somebody that was just naturally able to handle that kind of stress, or did this job help you to do that better? Like, how did you as a person fit as far as how you handle anxiety and stress?
I don't know if I have a great way of how it started. I don't know. I know in high school, I moved from Illinois to Pennsylvania. And that was still probably a life-defining moment for me in that I was a sophomore. So I think I kind of had to chart my own path and say, look, I'm either going to put myself out there and become more of an extrovert, which I'm not, to kind of get in the swim lane of high school, or you're going to just, I don't know, shrivel up. So I learned a little bit to put myself out there. So I don't know if that helped me, kind of down the path towards emergency medicine. I know I liked the variety, I liked the pace of it. That doesn't mean I couldn't have still done something else. I will say that the training shapes you a little bit. We discussed the PANP concept a little bit before, but that's kind of what's
Mhm.
in that regard with those that go into emergency medicine, because we spend 3 to 4 years just doing emergency medicine, and you really learn that suppression of that anxiety, right? When you're a first year and you're there, sometimes your heartbeat is going so fast you can't figure out what's wrong with anybody's. And as you mature through that process, that calmness comes about you, right? It's kind of like that high performance athlete that as the game goes faster, everything actually slows down for them. That actually is kind of
Yeah.
what occurs in emergency medicine training. You learn how to, as the situation may become unraveling more and more, there sometimes can be a sense of calmness that comes over you. And be honest, that calmness is what makes the room successful. If the physician who's the leader of the room or the captain of the ship at the time is showing their anxiety in an outward fashion, those that have a lesser education or lesser ability begin to panic, and then the team kind of falls apart. So we talk a lot about team dynamics and how to lead a team and be the appropriate leader of a team in a resuscitation room. And part of it starts from the calmness of the leader that's there, giving succinct, direction and orders in a calm fashion. And then everyone else in that resuscitation is allowed to move forward. And a lot of the way we manage care, whether it be from one situation to another or evolving from one room to another, has to have that element in it. Um, so sometimes we say if the first person's pulse you should check when you go into a room is probably your own.
Oh, I love that. Wow. And, in doing crisis work with children, I worked in some residential settings, and it's so easy to get sucked into that energy in the room. And you're saying you, over time, especially when you're more veteran at this, you can walk in and keep an equilibrium, even though everything around you is so heightened.
Yes, and
Yeah.
that can be anywhere from a person who is in distress to a person who's just angry because they had to wait, or they're upset about their diagnosis or their healthcare situation, and they're displacing that anger on you. Again, sometimes silence is your greatest friend. I'm not saying anything and just allowing things to happen,
Yeah.
and listen. So that's, you kind of got to learn to read the room really fast. That's kind of something that
Yeah. You just don't know what's gonna happen till you walk in there. Still hearing this sounds like something you hone over time. It's part of the training. You get better and better at it, but are there some people that are just not fit to do this kind of role, and how do they know that? How do they know that they're not gonna stay calm? They're not gonna keep their energy low?
Yeah, I think there's a couple of things. One, obviously through training, people are interviewed and they get into the emergency medicine residency. Not everyone that applies for emergency medicine residency gets in. Um, and those that do, then they start that training process and they get a lot of robust feedback through their training as to how that's
Okay.
going. How is strong is their voice during the resuscitation? What does that all, what does that look like? Their presentations, their ability to multitask and to handle different things at different times. That's that growth process through. Not everyone finishes a residency program either. I mean, most do, but there are some people that we find out that it's just not a fit. It's not personal, but it's not a fit. A lot of them see it but can't suggest that failure is an option, so they keep going. So having open and honest feedback during a residency training program is very crucial, and it does happen. The more I interview young graduates and residents, they're very comfortable with the feedback process. They get a lot of it, and so they're constantly getting critiqued on the way they do their profession, and how their growth is. And we ask them intently about what are they working on, what feedback have they gotten recently, and what are they working on. That's part of what we are interested in when we go to hire them. I will also say ERs are not all created equal. And where I practice is a trauma center. Not every situation is. It doesn't mean you don't get people from traumatic injuries, but the number of which you get are different.
Okay.
Some people choose to practice in environments that the chaos is a little more managed by comparison. And then there are people that
Not
tend
you.
to matriculate into the centers that are going to produce more high demand. And some of that changes over your lifetime. Some people start out in that environment and then later on in life say, I've kind of done that. I'm really interested in more of something that's, a little slower and less acute. And so they matriculate into those roles. It doesn't have to be defined based on your entire career, but some people make it a career.
So you are in what you would call probably the most acute setting, being a trauma 1. I believe it's a trauma 1 center?
It's a two, but with that said, yes, we're kind of a regional hub or tertiary care center, so that's where you have most of the
Mhm.
resources, and so most of the individuals that are sick or have sick defining illnesses tend to matriculate to those institutions because that's where the resources are. With that, we have the resources, which means we have some support or help, but yes, the cases tend to be more complex.
Yeah, you've got the life flight pad, like, you're definitely a place where we could be safe if something happens. I really love what you said about feedback. And I think about our clients and dealing with mental health. And if we could assist in a crisis and help them work through their skills, work through the cognitive distortions, it would be such a positive thing. And you're doing that through your training. So young doctors are learning or fellows to do that with someone over them guiding and feeding back. If we could give that to everyone with anxiety, they might come out in a better place too, like you are able to do. I love that that's part of it. And I love that you mentioned the thing about the voice. Even the way your voice is projected in the room has something to do with how you're commanding it.
Yeah, I think you have to lead with intent, but if your delivery is such that you're unsure of yourself, there's not a lot of confidence in what's happening there either. Now, there's open
Right.
feedback too in a resuscitation. Sometimes say, look, what am I missing? Does anyone else have any ideas or suggestions? That's a real thing that actually happens in a cardiac arrest situation. We'll ask to the paramedic, what am I missing? What do you think? To the nurse, we're all in this together. In the end, the physician's the captain of the ship and we make the final decisions, but input is welcome. You only have so many sets of eyes, but engaging the team in that process, asking good questions, but giving definitive answers and requests and orders, it is important.
And for those reasons you just said, someone has to be there kind of,
Yeah.
managing the energy in the room. And that lends itself to what I would think are other challenges too to being in the ER. This is one of them. You just mentioned the outcome is not predictable and it's not always going to be the outcome that you want.
Correct.
That or other things that you would say make it uniquely difficult for somebody in sort of this I'm saying first responder because you guys are usually the ones along
Yeah.
with the paramedics. What are some other challenges that people should know or that you are aware of or have heard of?
I think the hardest thing in our profession right now is kind of a lot of patients are coming for care and hospital capacity is where it's at. Boarding is no, ever increasing. So boarding is when someone is to be admitted to the hospital, but they're stuck in the ER and they can't get out. They can't
Yeah.
get upstairs. Because of that, we're leading to more patients in what we call like waiting room medicine, meaning you come in, you get seen, and then a lot of your care is happening or starting in the waiting room and you're there. Our health system's chosen to take more of a deliberate path in getting a provider there to see them, but it's not, you're not coming to the ER and getting put in, getting in a gown and putting in a traditional bed space and all of those things. It looks very different. And so I know when I meet with physicians and ask them what their greatest struggle is, majority of the time it's believing they left the day having failed their community because they couldn't see everybody that showed up that day. It doesn't mean that it wasn't a
Wow.
try or attempt to do so, but if you're at bed constraints, staffing constraints, resource restraints, a patient may choose to leave after showing up for a defined period of time. And to a certain extent, people feel like, they kind of failed that day.
Yeah. And so you, like every other part of our world right now, has some, like you mentioned, can be under resourced in some areas. But yours is life or death sometimes. It's not like those of us that have to pay more for bread. It seems to have a bigger impact.
Well, it does. And I don't want people to leave with the thought that emergency care isn't still there, right? Emergency is
Right.
very different for everyone. I ironically define emergency probably different than everybody, but everyone's emergency is different. And so if someone comes for let's say knee pain, depending on what their health literacy is, their knee pain is very important to them and it's an emergency. The cardiac arrest is not going to get under cared for. The stroke patient's not going to get under cared for. Those resources are always available for those kind of well-defined emergencies. But there are people that don't have the resources, care opportunities, or otherwise to get their care, and they still come to us. Those are the ones that tend to wait more often, and those are the ones that tend maybe to leave. But
Yeah.
there's still a sense of ownership that we have to care for those individuals too.
That's a theme that I've heard throughout people that I've interviewed for this series is that the distress tolerance and potentially the mental health part of our community is coming into these roles and it's not always the right fit or at least it's not set up for that. So the firefighters will say they're going to calls that really aren't emergencies and they're putting on the lights and cruising down the road, but they don't need to. I'm getting the sense you're seeing a little of that too, where they could be served somewhere else other than the emergency room potentially.
Potentially,
Yeah.
a lot of listen, we all have primary care physicians. There's something wrong. You call, you get advice. Maybe it's late in the day. Maybe what's relayed to the provider is heard in a different light. It sounds more concerning. Based on their history, they have a gestalt that tells them this is a concern. In the end, when they come in, we may rule that out and able to get them home. The patient may feel like that was a waste of time. Had their doctor been right, it was not. Listen, the positive side of this is that we went through the exercise of defining whether there was an emergency or not. And so
Yeah.
not everything has to look like an emergency to be one, and some things that look like emergencies just aren't. And that's very individual depending on where you're at with your stress tolerance, what your life journey has looked like, what your own personal medical history looks like, what events have happened to you and your family. So defining emergency is really difficult. for all of us.
Yeah.
And I do think it's changed over time through the pandemic and with some of the mental health crises that are out there.
I love your human approach to that. I love how you answer that because you're looking at an emergency from the eyes of the patient, not on a clipboard of, do you fall under these 5 triage pieces? And I really appreciate that because we see that here too. What looks like an emergency to one person might be different to somebody else.
I think a lot of that, it helps the provider at the bedside too, is that they did not come in to waste your time, right? They came in for care because their
Right.
perceived issue was an emergency to them. And again, I use the word health literacy, but people's understanding of their own healthcare is variable. I went to school and all my colleagues went to school for healthcare. We have a very large understanding of what it means and how to diagnose and what symptoms mean. If someone else was in business or finance or something else, they don't. They're concerned for a very different reason. Sometimes we're able to invalidate that reason very quickly and with little resources, and sometimes it takes more of a workup for that. But it doesn't mean that it wasn't an emergency to that person. I think that's one of those things that you see people that start to trend towards burnout kind of forget to realize as
Yeah.
resources get harder.
Yeah. And we're going to talk about burnout in a minute. Are you seeing more or the same of mental health crises? How often do those? We were just in a conference call this morning and this came up. I don't know if your ears are burning, not you specifically, but we were using Cleveland Clinic in another way. And the how many people are coming through that need to be sent somewhere else or into your psychiatric areas?
I don't know if I have a good sense of the actual number, but I will say that as things have changed coming out of the pandemic, the amount of resources that are available have changed, right? I mean, there's been pop-ups
Okay.
of some virtual care, which speaks to some generations and not to others, but
Yep.
inpatient units have varied, capacity for which has changed, their resources, right? How many staff members do they have that they can hire for? Is the unit
Right.
fully staffed? So they may, let's say we had 100 behavioral health beds within a defined area of the city. Maybe only 75 of them are open because of staffing. That's a real problem that we face sometimes. I
Yeah.
do think behavioral health care is a challenge, and as patients are on down that continuum, some of them need more supervision or care to help mitigate aggressive behavior, and that changes the staffing model too, which can lead to different challenges.
Yeah. So you're really at the mercy of where they can go based on availability in other places. It's not just your ER that owns that. You just basically
Evaluate, treat them, and get those things started. But if they need true placement into a bed that allows them to have continued care, that is another resource that has to be available for us. And if it's not readily available, we do hold those patients in the ER for a period of time until that resource
yeah.
becomes available. That is both from an adult standpoint and a pediatric standpoint. And I think we've really seen the greatest growth in mental health need in our adolescent pediatric population, and for which we see a lot more of the holding, boarding, and restraint, issues with lack of better.
Yeah, and we see that too. That's why it was important to me to talk about that because the beds you mentioned, that is a place to put people, and if we don't have them, I know I've had clients float in settings where they just don't belong because there's nowhere for them to go, not particularly an ER challenge. Is there a vignette or a quick story of a ER experience? Like, what is anything happened that you can think about? I know I kinda threw that at you, but I'm just kinda curious. You seem to have so much experience in your
Listen, I feel like more and more every day that I work, I'm diagnosing someone with cancer. So that's a real thing. They come in with maybe benign symptoms or something else, and we find cancer, and we're sharing that.
yeah.
Um,
Which could be life-saving if you're finding it there. I mean, that's powerful.
it can be. Sometimes we're finding it early, and sometimes we're finding it late. Uh,
Oh, okay.
in both
Not yeah, I'm going for my positive approach, but not always.
Yeah, so
Yeah.
right, and sometimes we find things that really in my heart of hearts, I know is probably cancer, but I can't always say that. So we found something that's abnormal that looks suspicious and it's concerning, and we're going to get you the right appropriate setup to get to the next steps. But those are hard cases. I think again going back to the boarding and the delays in care and patients waiting in the waiting room. I think one of the things that is stands out for me now is sometimes the good catches we're having. Patients are waiting more into the waiting spaces. They're receiving care and getting imaging, and we're able to kind of, what we say typically is making our waiting rooms a little bit safer. If they hadn't been seen or weren't getting imaging, those people may be waiting for undefined number of hours, not getting anything started. So as we are starting it, sometimes we're finding things like non-ruptured aortic aneurysms, like what we call an NSTEMI, which is a heart attack in evolution to where their EKG hasn't changed, right? So an EKG tells you whether someone's having an active heart attack that is of a defined distribution to cause that EKG to change. Some people are having more subtle things that the EKG doesn't change. So we're finding a lot of those in patients who are waiting. And then we're able to
Mhm.
escalate care and get them to the appropriate care area as we go. But that exercise that we go through is really designed to make sure that we're providing efficient care and safe care, and then not having those misses. We call them near misses because traditionally I would love to have them been back in a room when it was fine. But either way, we're still closing the gap.
Yeah, and that's a really good point that people are coming in and you have this opportunity to explore what might be going to happen, almost a preventive approach in a way,
Correct.
depending on why they're there.
Sure.
So just hearing that part of what you said, everything you've told me, it almost makes me feel a little tense just to think about the things that don't go well, the stories that are tough. How do you take care of you? What is your self-care regimen? And maybe this speaks to you or what some of your supervisees do, but how the heck do you handle that at the end of the day?
It's hard. I can't say that some of us don't take a little of that home, or maybe you don't spend that time ruminating. I think a lot of emergency clinicians we say are reflective, meaning it's not always bad to have a 30-minute ride home. Because
Yeah.
you spend that time kind of reflecting about what you did right, maybe what you did wrong, and or what you could have done better that day. I think that goes a long way to kind of help. I do think we try to keep a fairly robust openness. So if someone had a bad day, I expect them to call me. I
Okay.
expect my team members to sometimes call me in the middle of the night. That's a very realistic expectation for all of them. Is that I would much rather know about something in real time to help either manage that or get you through that than find out about the bad outcome the next day. But we have to be there for each other to have those conversations. And then when someone's identified that, listen, they are struggling with a challenge that happened, or they're not able to, kind of come to grips with something they witnessed, saw, or otherwise, then we do have resources to kind of point them in the right direction to help them out, whether it counsel therapy or something else to help them along the way. We're intentional about putting those resources out there in a lot of different ways. End of staff meetings, end of peer review meetings, we just include it all the time so that it's open and kind of understood, because most people, I think it goes underutilized, right? A lot of us could probably benefit from it and don't take the opportunity. And so we kind of
Right.
put it out there in abundance, hoping that we kind of catch the people as they're defining. I know sometimes we also, if there's a bad day, as a director, I find out about it. Maybe there was somebody who passed that was unexpected. Maybe it was a child, maybe it was an adult who was younger. We check in on the staff too. How's everyone doing? Sometimes we'll order food. We do have spiritual care come to the department occasionally. Sometimes leadership obviously comes in to support the team. Sometimes to send people home, right? So we bring different people in and then send
Yeah.
people home because they need a break from whatever occurred. But I think we talk openly about it. It's not something we sweep under the rug, but it's not unheard of for a physician to go from one room that was a death and then go right back to the bedside and start talking about belly pain again. And you have to learn to
Right.
compartmentalize that as well.
And then your to your point, it might come out later on your 30-minute drive home. There still might be a debrief opportunity. And I've heard you mention that a few times that you do have this protocol, if you will, of debriefing. We discuss the case and we see if everyone's okay or needs intervention.
Right. And I think that's
Yeah,
important. I mean, so we do something every death it's called the pause, and it's not a spiritual thing, but it's just more recognition that this is a father, a mother, a child, a friend, and we just reflect and take a moment of silence for them. I think that helps. I do think then sometimes the teams will gather together real quick and say, look, hey, great job on doing this, or that skill that you performed was amazing and great job. But what else could have we have done or something different? We always talk about that during the case, but then afterwards as well. That way no one leaves with the sense of feeling unheard, and then they take that home too. So
it's like the processing, the talk therapy, if you will, but you're doing it amongst each
a
other.
little bit, and unfortunately, it's quick, right? It's
Yeah.
kind of 1 to 3 minutes, sometimes maybe five on a moment, but then there are others that are always waiting. So we have to kind of get back to the mission.
And if somebody isn't in a role right now and they're listening in some way, they might not be an ER doctor, they could be one of the other staff you mentioned. Depending on whether or not their hospital has this in place, where do they go? How do they ask for this help? Who's the next person to say, I need help, I'm struggling?
I think for people that don't, the clinic is obviously a robust system that has a lot of things to develop and support its team members. I think if you're somewhere that doesn't have those resources, I think you start asking questions. And it can start small. It can be just
Yeah.
intentional acts of saying, look, after every death, we're going to talk and just do a quick debrief, right? That's something that anybody can do anywhere. And I think then if you get into the step of finding out that people are having some personal challenges, I think it's very realistic to say, look, there are resources within the community. So maybe we're going to partner with a psychologist or a psychiatrist that can do a next day appointment as a favor to the medical community to say, hey, we have someone struggling here. Is there a way we can intervene? But I also think that the simple things matter. So being open and intentional about the conversations, speaking about it, making it okay to be upset, making it okay to that someone can walk away for 1 to 5 minutes to be upset, and to be frustrated, and not have that looked at in a negative fashion.
Yeah.
Because we're all human, and it's going to happen. It may happen to me today, and maybe hit you tomorrow. And me being there for you makes a difference, and so they'll be there for me.
And I want you to be human. That word's come up a few times. Sometimes people look at physicians and the medical staff as these unreachable, white coated people, and you're humans too. And we need you to be that. So I love that. And you mentioned open. Again, another theme that's come up is that maybe it always didn't look this way. I have heard that what's been really nice in the first responders world is that people are open to talk about mental health. They're open to say, I need a break. You mentioned the pause. And am I correct in hearing that that's happening as well in the ERs? Maybe it's even becoming more robust to your term?
Yeah, I think it is. I
Mhm.
will tell you, it's getting harder, right? As we get busier and there's a backlog, right? So you want to take that moment, you want to take that time to do what's necessary, but there is always somebody waiting, and there is always somebody who's there for care. And I don't want to
Yeah.
suggest that they're not empathetic to what you just experienced, but they'll say that's your job and now it's my turn. And so
That's a great point.
you kind of have to compartmentalize it and get through your shift. Sometimes maybe it happened toward the end of your shift, so you have a very defined period of time and you're almost done. It has occurred where we've called the next shift in early, right? Again, to try to get someone home. We have had people that say, "No, I'm fine," and they work the rest of their shift, and seemingly it's fine. And then 2 to 3 weeks later, we find out that they're not fine, right? And
Right.
but I think you also got to take that act of checking in on people. Texting them the next day, "How you doing? Do you want to talk? Okay, you don't,
I like that.
but I'm willing to listen."
And that's your role, right? As their supervisor, you said you're available for that, or you might check in.
Yeah, I don't know if it's defined. I mean, I don't know. I think it just happens. I think it's part of our culture. I think
Yeah.
it's, as the
Okay.
directors that I have hired that supervise other sites that report to me, that's an expectation of mine that we do those things. I don't think it's defined or written down or anything like that. But I think as we intentionally care about each other and the patients we serve, I think you go that extra step to check in on them.
Yeah. And this is tough. I mean, just
Sure.
hearing about it's tough. There's got to be the need sometimes. And then I'm also catching that at some point, most people, and even you said you've got the drive home, or some people do, there has to be some way that you give yourself a release when it's all done because you are holding on to it. You would have to do your job.
Yeah, I think everyone, we do check-ins with our docs and our PAs, and nurses do too. So we sit down and intentionally do that, a couple times a year. And I kind of ask them, like, what do you do outside of work, right? It's not part of the performance evaluation, but I ask them, what do you do?
Yeah.
A lot of times I know because some of these are friends and colleagues, but you have to have a life outside of the crazy world of emergency medicine. We work different hours, and so sometimes nights, holidays, weekends. So we have different times off, and some people do exercise classes. They have different hobbies that are art related, or maybe it's music, and that helps speaks to that calmness that they need in their life to kind of get away. Some people need a shift reduction for a few months where they just work less clinical shifts so that they can get more of a break and do that time off. Along the way, what speaks to me may not speak to you, and what that calmness brings is different. But exploring that with different
Yeah.
individuals, I always find different things that are interesting, and then that helps kind of advise other people of what other people do for their stress reduction.
Yeah, I like that it's an open conversation. You said a couple times a year it might come up and everyone kind of shares, what do you do to decompress after these kind of events? And the hours, I forget about that sometimes. We know how important circadian rhythms are. So when you are altering your hours too, that puts you a little more at risk.
It does. I think we spend a lot of time on making sure the schedule fits, right? I think a lot of people go into emergency medicine also because it is shift work. You can kind of go and then you leave it at work, provided you're
Yeah.
not in a leadership position like myself. But they like that aspect of it, but their schedule is really important to them. So we try to make sure that if there's an event that's special to them, for their family or others, that they are there for that, which makes set 2 a.m. on a Friday night when they're working. They think at the back of the mind, yeah, but they're off for their daughter's birthday party next weekend. So those things are
Yeah.
important too as a trade off for that. But shift work, you have to take that into account, and we have to make sure that the schedule fits so that I'm not intentionally hurting their recovery time by scheduling them in a way that's not going to allow them to be fully present when they're on duty.
So there's thought about that. Not everyone's body's going to respond
There's a lot of
the
thought
same.
about it, and it changes over time, comparative when you're
Yeah.
younger to when you're older, and how you recover and move.
Or like you mentioned, if you have a family, your obligations are different.
Sure.
They're gonna look a little different. You mentioned burnout. How does someone know they're burning out? How do they know whether they need a little break or a big break? Any ideas on a gauge for that?
I don't know if anyone really knows. Usually someone tells you.
I'm supposed to be the one that knows, right? But you have to sit with me for an hour and then I'll tell
Yeah,
you.
I don't think anyone knows. I think you kind of, there's a lot of tells. So I'll see
Do you see the tells?
as their boss, yes, or someone will come to me and say, "Hey, I'm concerned about somebody," or they
Okay.
just haven't been the same, right? So
Mhm.
if you're that person that comes on shift or on duty and you usually are pretty jovial, happy, smiling, and you're not,
Yeah.
or you're short with maybe a patient or a nurse or somebody else when normally that's not your behavior. It's a conversation. Now, a lot of times it may be more stuff going on at home than it is at work, but
Combo.
it's still a question that gets asked. Like, is everything
Yeah.
okay at home? I don't need to get into your personal life, and I don't want to solve it for you. But if it's personal, then it's a different conversation. But if it's professional and you're burning out based on either a tragedy or something's helped, again, that goes back to can we get someone some counseling? Do they need just
Yeah.
somebody to talk to outside of as their leader? I'm always happy to do so, but sometimes it feels it's a different vulnerability to let your boss know that you're struggling with something. So we
Absolutely.
offer that challenge for them outside of the organization to try to figure out what the next steps are. But usually it comes to me that somebody else has recognized that things aren't going well with somebody. And so we just offer a bridge conversation.
And because you have such a team approach, it sounds like someone on the team is feeling okay to come up and kind of to pull the Honda string, if you will, and say, "Hey, I see something." And it sounds like that's what's happening, which would be so important.
Correct. You mentioned the Honda thing. So the automotive industry, we talk about psychological safety a lot
Yeah.
within our
Right.
organization, right? That's where it comes from, and Toyota
Yeah.
or Honda. But we talk about that in every aspect, whether it's the EVS person that walks by a room and says, she just doesn't look good. If I said, I don't know, go clean the floor, they're not going to tell me the next time. Um,
Right.
and I'm going to thank
Right.
them probably twice, and I'm going to go see the person so that we get that level of accountability. But you have to be open to all that. But again, that goes back to the culture that is asked upon to be a leader within our organization.
Yeah. And of an ER setting where there's a potential for people to
100%.
struggle or burn out or
Yeah.
so is there anything that you think I don't know if this would it sounds like Cleveland Clinic's doing a good job, but anything you think could be added to help with managing this kind of role? Is there anything you kind of dream about that, "Oh, wouldn't it be great if we had a wellness center or we had something?"
Yeah. We've toyed around with like a wellness officer in the past, and that's still
Mm,
being kind of banted about, and we do things with that. The hard thing is that it's that the term and what's required of that is very different for everybody. And we used to do a
yeah.
little segment in every staff meeting that talks about wellness and what that means. But because it's individual, it's hard. What we've
It's
done,
like healthy.
yeah, like I might
What
want to
does
go to
that
the
mean?
gym, and someone else may just want to go read a book by themselves, and
They both count.
both speak to wellness.
Yeah.
So we offer different things like every other job. I mean, there's a book club that someone's doing, and people meet for yoga, and there's people are going snow tubing, I think, in a couple of weeks here together. And so we do things outside of work, and a couple times a year we've been blessed with some money with philanthropy to do some engagement type events where we go bowling or something else. We've gone kayaking in the past as a team. And so it just gets you to see people outside of work because we're all real people, and we're not really
That's a
as defined as we need to be. So we're all human. We get out there, we have fun, and get
yeah.
together. And some of us do like summer picnics and things like that in the summer months too, for the same reason.
That could be the key right there, is the team being the team even when they're not in crisis.
Yeah, I think, again, it just makes all of us feel, there is a hierarchical structure to our team, but at the same time it's okay to be friends, right? And I think that's the interesting part of it. People most days call me by my first name, and I'm perfectly fine with that. But we all know when we're at bedside, I have a role and I'm called by that. And I think it's just defined, it's respect, top down. But we need to have fun outside of this place too.
Yeah, and that's the balance, isn't it? And it sounds like you've struck it. That's why you're where you're at and can have this conversation.
Sure. I don't think we struck it. I think we still strive for it. How's that? I think we still
Yeah,
always.
fair
I
enough.
think we're all working for it.
Well, it's an ongoing thing. Like you said, wellness is relative and so is when and how we use it. So it is ongoing and I don't think it ever goes away either.
No.
I'm just glad we talk about it. Do you have a piece of advice for someone listening that either wants to work in first responder ER role or is currently anything to maybe that highlight what you've already said or knew about what they should think about or know?
Listen, I think if it's your passion, maybe most people I think go into this, they feel unsure. It seems like a very daunting thing they feel unsure. I'd say you just jump in with both feet. If you have a passion for helping people, it's a great opportunity. You have to take it a day at a time. It's a long road to learn, no matter where you're at in the role, but it's rewarding. I can't think of a better way to help those in your community. And so I would say just keep working hard at it. I think you'll enjoy it over time. There will be good and bad days, but remember the good, try to forget the bad, and move forward.
I kinda like being able to accept that this isn't going to be the rainbow unicorn job. You're taking this job because you know sometimes you're going to see and be a part of things that are not going to be positive endings.
Correct.
Same with firefighters, same with police department.
Right. You go to work to have a great day, and a lot of days you come home and maybe it wasn't, but that wasn't your fault. It wasn't your doing,
Yeah.
but you were there for somebody.
Yeah, your role is still so imperative.
Right. Right.
Yeah, and you mentioned earlier, you said something like 30. Is that how many people come through the ER sometimes? Is that a number you just threw out or
No, I mean, that's the number of people I try to see on a shift. But I mean, so Hillcrest sees about 140, 150 people a day where I'm at. Each ED sees a different number. Some EDs will see up to 200. Some will see only, 70 or 80. It depends on their size, capability, capacity, where you're at. So that's just a rough number that I would throw out to you. But, you try to impact a rough number of people's lives every day I'm on duty.
and that there's opportunity.
Yeah, mine is as a leader and a director is to impact more lives as you help foster those who are at the bedside when I'm not.
I love that, and I like that, sort of the approach you have. It sounds like it's a good one to keep you and your staff on top and managing well, even with all the pressures. Is there a word, any word or a little word or a sentence to describe how you balance all this? It sounds like you've come up with something at least manageable for now.
I don't know if there's a word. I think it's kind of an attitude of just empathy, right?
Like that?
I think that speaks to the patients, that speaks to your coworkers,
Yeah.
kind of up and down. So I'll say empathy, but I don't know if there's a good word for it specifically.
I think it's a great word.
But I think that allows you to be empathetic to yourself, empathetic to those around you. And if we are empathetic towards each other, I think you at least leave the day somewhat positive.
Yeah, I think that's a great word. I love that word, and I don't hear it as much as I should. It's an outward and an inward expression of the emotion, so I appreciate that. And I appreciate, again, your time. I love this conversation. It just opens up more of what's going on that we take for granted out those people out here, and then also for people in your line of work understanding what their resources are and the challenges that you get as well. I appreciate your time in this conversation.
Perfect. Thank you.
Thanks for listening to the Mental Health Spotlight podcast, helping you hold hope on your recovery path.